miserable reality of the head cold. You know the feeling I'm talking about.
Oh, absolutely. Unfortunately, I think we all do. It's a universal misery.
It really is. It's that feeling where your head feels like it weighs about 50 pounds, your throat feels like you've swallowed a handful of, I don't know, broken glass, and your ears are doing this weird popping thing every time you even think about swallowing. It is the absolute worst.
It is, and medically, we have this very sterile, dry term for it. We call it an upper respiratory tract infection.
Doesn't sound nearly as bad as it feels.
Not at all. But that one umbrella term, it hides a whole lot of specific misery. And it accounts for, millions and millions of doctor visits every single year. It's the bread and butter of urgent care clinics everywhere.
Right. And most of the time, we just complain, we chug some orange juice, and we wait for it to pass. But today, we're doing something a little different. We aren't just talking about the common cold virus, the one that gives you the sniffles for 3 days. We are digging into what I'm calling the trifecta.
The trifecta.
Like that. The 3 major complications that can take a regular, just annoying cold and turn it into a real medical situation that needs intervention.
Exactly. This is where we separate the nuisance from the actual infection. So we're talking about the ears, that's otitis media, the throat pharyngitis, and of course the sinuses, rhinosinusitis.
And our mission here is really specific. I think a lot of us, myself included, we walk around with this vague idea of, oh, I feel terrible, I think I need antibiotics, but we don't actually know why we think that. We just base it on the level of suffering.
Yes, the misery index.
The misery index, exactly. But the clinical consensus and the deep dive we've done into the respiratory guidelines for this, it says that suffering isn't actually a diagnosis.
And that is the hard truth we're going to unpack today. The intensity of your pain, it doesn't always correlate with whether you have a bacterial infection. The guidelines we're looking at, especially Chapter 44 on these infections, they're incredibly strict. They rely on very specific, observable evidence.
So we're going to arm everyone listening with that evidence. We want to give you the diagnostic checklist so you can look at your own symptoms, or more often your kids' symptoms, and say, okay, this isn't just a cold anymore, this is something else.
Right.
So let's start with the one that I think causes the most lost sleep, specifically for parents, the ears.
Otitis media.
Otitis media. Now, I saw a statistic in the research, and I honestly had to double check it. 709 million cases worldwide.
Annually.
It's a staggering number, isn't it? 709 million. And just to give that some context, that is more than double the entire population of the United States every single year dealing with an inflamed middle ear.
And the demographic skew on this is massive. The source says half of those cases are in children under 5 years old. That's right, 50%. It is overwhelmingly a disease of early childhood.
Okay, so before we even get into the infection itself, we have to answer the why. Why are toddlers the target audience for this particular brand of misery? Is it just because they're in daycare, licking the floor and sharing germs?
Well, the hygiene part certainly doesn't help, but the real reason is actually an issue of plumbing. It's anatomy.
Plumbing in the ear.
In the ear. Think about the eustachian tube. This is the little canal that connects your middle ear, that's the space behind the eardrum, to the back of your throat.
Okay.
Its job is to drain fluid out and to equalize pressure. You know when your ears pop on an airplane? That's your eustachian tube working.
Right, right.
Now, in an adult, that tube is relatively long, it's firm, and it's angled downward. So gravity helps it drain everything out.
Makes sense.
But in a child under 5, that same tube is shorter, it's floppier, and this is the crucial part, it is almost completely horizontal.
Oh, I see where this is going. So there's no gravity assist.
None at all. So when a little kid gets a cold, just a regular viral upper respiratory infection, what happens? All the mucous membranes swell up.
Everything gets puffy and inflamed.
Exactly. And that horizontal tube gets pinched shut. So any fluid that was in the ear or any new fluid that's created gets trapped. It's like a stagnant pond with no outlet. And what happens to stagnant water?
Things start to grow in it.
Precisely. It becomes this warm, dark, nutrient-rich breeding ground for bacteria. And that is the fundamental mechanism. It almost always starts with a virus that compromises the plumbing, and then bacteria move in to colonize the stagnant pool.
So it's a 2-stage attack. The virus comes in, locks the door, and then the bacteria come and rob the house.
That is a perfect analogy. And the robbers are usually the same 3 suspects. We call them the major pathogens of the upper respiratory tract. You've got Streptococcus pneumonia, Haemophilus influenza, and Moraxella catarrhalis.
Okay, I want to pause on that first one, Streptococcus pneumonia, for a second, because in all the literature, this one seems to be the main villain of the story.
It is the heavy hitter, for sure. You can think of strep pneumo, as we call it, as the tank. It causes about 35 to 40% of all these bacterial cases, but it's also the one most likely to cause complications.
Right.
And unfortunately, it's the one that has become the most stubborn when it comes to antibiotics.
Okay, we'll definitely come back to that. But this brings us to the diagnosis, because this is where I think most parents, and probably even some doctors in a hurry, get it wrong. I always assume that if my kid is screaming, tugging their ear, and I look in and the ear looks red, that's an infection. Boom. Antibiotics.
And that is what we could call the redness fallacy.
The redness fallacy. I like that.
Yes, the clinical guidelines are extremely clear on this point. Redness, or erythema, the technical term, is not enough for a diagnosis. Think about it. If a child is screaming and crying for an hour, their ears turn red.
True.
If they have a high fever from any virus, their ears can turn red. Even just the viral inflammation itself can make the eardrum look red. It's a non-specific sign.
So what are we looking for then? If redness isn't the smoking gun, what is?
You need a trifecta of your own, actually. You need 3 specific things to happen at once. First, an acute onset of symptoms, the sudden pain, the fever. Second, visible signs of inflammation, which can include redness. But the third, and the most critical sign, is the bulging of the tympanic membrane, the eardrum.
Describe that for us. What does a bulging ear actually look like compared to a normal one?
Okay, so imagine a drum. A normal, healthy eardrum is sort of translucent. It's a pearly gray color, and it sits nicely in a neutral position. You can often see the little bones of the ear behind it. It's quite delicate.
Right.
Now imagine you pump pressurized water, or worse, pus, behind that drum skin. It bows outward. It loses its landmarks, looks angry and opaque and red, and it is physically distended, pushing out towards you. That physical bulge is the key. It tells you there is purulent fluid pus trapped under significant pressure.
That sounds incredibly painful.
It's excruciating. That pressure is why the kids are screaming, especially when they lie down, because it increases the pressure even more. But without that clear visual evidence of the bulge, you cannot definitively say it's acute otitis media or AOM.
So what could it be otherwise? If it's red and they're in pain but it's not bulging?
It could be what's called otitis media with effusion, or OME. That means there's fluid, but it's not acutely infected. It's more like fluid after a cold that just hasn't drained yet, doesn't need antibiotics. Or it could just be a red ear from the virus. So the bulge is the decider.
Okay, so we have a screaming child. The doctor looks in and sees the telltale bulge. We have the diagnosis of AOM. Now here is where the guidelines threw me for a complete loop, and I think this is going to shock a lot of listeners. The recommendation isn't always start antibiotics immediately.
No, it's not.
It's wait and see.
The technical term is observation with close follow-up. But yes, in essence, wait and see.
Okay, play the skeptic with me for a second here. I'm a parent. My child has not slept in 2 nights. I haven't slept in 2 nights. I have dragged them to the doctor. And you're telling me to go home and wait. That feels like negligence. It feels like you're not doing anything.
It absolutely feels that way. I completely understand that perspective. But let's look at the data that drives these guidelines. The studies, multiple large-scale studies, show that a huge percentage of these infections, even the ones that are confirmed bacterial, will resolve on their own within a few days.
Without any drugs.
Without any antibiotics. The body's immune system is incredibly capable of clearing that middle ear space if it's just given a chance.
So the goal is just to avoid the drugs.
The goal is to be prudent. It's about antibiotic stewardship. Every single time we use an antibiotic, we risk side effects. Diarrhea is a huge one for kids, which can lead to dehydration, and more importantly, we contribute to the global crisis of antibiotic resistance. So the guideline says, if the child is over 2 years old, or if they're between 6 months and 2 years old, but the symptoms are not severe.
And what does not severe mean in this context?
Not severe means no super high fever, so less than 102.2 Fahrenheit, and no toxic appearance. They're still interacting, they're not listless. In those cases, we can wait 48 to 72 hours.
And in that waiting period, you just treat the pain.
Aggressively treat the pain. That is the non-negotiable part. You should be giving scheduled doses of acetaminophen or ibuprofen around the clock to keep them comfortable. But yes, you hold the amoxicillin.
Does that strategy actually work in the real world? Or do most people just end up coming back 3 days later even more frustrated?
A significant number never come back because the child wakes up on day 3 and is completely fine. The fever is gone, the pain is gone, the body won. But you absolutely have to have that safety net. That's the close follow-up part. The doctor should say, if they're not significantly better in 48 hours, or if they get worse at any point, here is the prescription. go fill it.
So the prescription is ready to go. It's a delayed treatment plan.
Exactly. It's not go home and good luck. It's go home with a clear plan and a trigger for action.
Okay, let's say they aren't better, or let's say they're under 6 months old, or they have 104 fever and look terrible from the start. We are treating them. The weapon of choice is amoxicillin. But the source material was very specific about high-dose amoxicillin. Why does the dose matter so much?
This goes right back to our tank, Streptococcus pneumonia. Over the last few decades, through exposure to antibiotics, this bacteria has evolved. It has altered its protein structure to build thicker armor, essentially.
So it's harder to kill.
Much harder.
Right.
The standard doses of amoxicillin that worked perfectly in the 1990s, they simply don't achieve a high enough concentration in that middle ear fluid to kill the modern, more resistant strains.
So we have to flood the zone, so to speak.
You have to flood the zone. We use 80 to 90 milligrams per kilogram of body weight per day. It's a huge dose. We have to flood the system to overwhelm the bacteria's defenses. If we use a lower dose, we risk a really bad outcome. We might just annoy the bacteria. We kill off all the weak ones, the susceptible ones, and we leave the super resistant ones behind to multiply without any competition. We're essentially breeding superbugs in the child's ear.
That is the nightmare scenario.
It is. And if that high-dose treatment fails, if the kid is still sick after 3 days of high-dose amoxicillin, we have to assume the bacteria has an even better shield. We assume it might be producing an enzyme called beta-lactamase.
That sounds like science fiction. Bacteria producing enzymes to eat our medicine.
It's evolutionary warfare happening in real time. The beta-lactamase enzyme literally finds the antibiotic molecule and chews it up, rendering it useless.
So what do you do then?
In that case, we switch to a combination drug, amoxicillin clavulanate, which you might know by the brand name Augmentin.
Right.
The clavulanate part is the key. It acts as a decoy. It doesn't kill bacteria, but the beta-lactamase enzyme loves to chew on it. So while the enzyme is busy attacking the decoy, the amoxicillin can sneak in and kill the actual bacteria.
It really is a tactical battle at a microscopic level.
It is. But before we leave the ear, there's one more thing that parents always ask about, constantly. Can I just give them a decongestant? Can I give them some Benadryl to dry up all that fluid?
Yeah, that makes logical sense. If the tube is blocked with fluid, dry it out.
And the guidelines are absolutely brutal on this point. They say, in no uncertain terms, do not do it.
Why not?
Because multiple studies have shown it offers minimal to zero benefit for the actual ear infection. It doesn't help unblock the eustachian tube, but it absolutely comes with side effects, especially in young children, agitation, drowsiness, sometimes even heart rate changes. You're just drugging the child without fixing the underlying problem.
So, just to be crystal clear, stick to painkillers, skip the cold medicine for ear infections.
Loud and clear. That's the recommendation.
Okay, so let's travel down the eustachian tube, past the uvula, and land squarely in the throat.
Segment 2, pharyngitis.
The dreaded sore throat. Now, I feel like the stakes are different here. With the ear, it's mostly about pain and maybe temporary hearing loss. With the throat, I feel like everyone is terrified of one thing, the strep.
Strep throat. It has an almost legendary status.
It really does. Every single time I get a scratchy throat, my brain immediately goes, oh no, is this strep? But the numbers you pulled from the research suggest that I am almost always wrong.
Statistically, yes, you are almost always wrong. And so is everyone else. Pharyngitis, which is just inflammation of the throat, the orifice or nasopharynx, is overwhelmingly viral. We're talking about rhinovirus, coronavirus, adenovirus, the usual suspects.
What are the actual odds? Lay them out for us.
In adults, Group A beta hemolytic streptococcus, or GABHS, that's the full name for the bacteria we worry about, it only accounts for about 5 to 15% of sore throats.
Wait, say that again? 5 to 15?
5 to 15%, which means up to 95% of the time an adult has a sore throat, it's just a virus. It's a cold.
Wow. So 90% of the time, I'm just wrong.
Pretty much. In kids, the rate is a little higher, maybe 20 to 30%, because they have less immunity and are in close quarters. But even then, the vast majority are still viral.
That is a huge disconnect from how we behave. People rush to urgent care for a throat culture the second it hurts. So how do we tell the difference? Is there a way to know without getting swabbed?
There is. And this is probably one of the most useful clinical tools we can give the listener today. It's the what it is not list.
Okay, I'm ready. Lay it out.
The single most reliable indicator that you do not have strep throat is the presence of a cough.
A cough, that's it.
If you are coughing, if you have a runny nose, what we call coryza, or if you have pink eye, conjunctivitis, it is almost certainly viral. Strep does not typically present with those symptoms.
Hold on, can you explain the biology there? Why wouldn't strep cause a cough? It's all connected, isn't it?
It is, but different pathogens have different preferences. Think of it like real estate. Group A strep loves the tonsils and the pharynx. That's its prime territory. It doesn't typically possess the right receptors to effectively infect the lower respiratory tract or the nasal mucosa in the same way.
Ah.
Viruses, on the other hand, are less picky. They'll set up shop anywhere. They infect the whole respiratory tract, the nose, the throat, the lungs. So if you have that whole constellation of symptoms, you can be very confident it's a virus. You don't need antibiotics.
That is incredibly helpful. So if I have a cough, I should just stay home and make soup.
Exactly.
But what does actual strep look and feel like then? If it's not the cough, what is it?
It is the sudden onset. People with strep often say they went from feeling perfectly fine to complete agony in just a few hours. It hits like a ton of bricks. High fever is common. And the pain with swallowing is often described as sharp, not just scratchy or sore.
And visually, if we do the mirror test with a flashlight, what are we looking for?
You're looking for a few key things. First, the whole throat might look beefy red. The tonsils might be swollen, sometimes with white spots or exudate on them. But the two most specific signs are a swollen red uvula, that's the little punching bag in the back, and petechia.
Petechiae. Those are the little red spots, right?
Yes. They look like little red donuts or tiny pinprick hemorrhages on the sauce palate, the roof of your mouth, way in the back. If you see those spots, that is highly suggestive of strep.
Okay. So, to recap the profile, sudden pain, high fever, red spots on the palate, and crucially, no cough.
That's the classic profile.
Yeah.
But even then, with all those signs, the official guidelines say you cannot and should not diagnose it just by looking. You need a positive test, either a rapid antigen test or a throat culture.
Why are we so strict about confirming it? And actually, that brings up a bigger question. Why do we treat it so aggressively? I read in the source material that strep throat usually just goes away on its own in 3 or 4 days anyway.
That's completely true. Even without any antibiotics, your body's immune system would clear the bacteria from your throat. The sore throat would resolve.
So why are we taking penicillin for 10 full days if the pain stops on day 3? It really seems like overkill.
And this is the most important point to this entire segment. It's the scary part. We don't treat strep to fix the throat. We treat strep to save the heart.
The heart. How is a sore throat connected to the heart?
We are preventing those non-suppurative complications I mentioned earlier. The big one, the one we truly fear, is acute rheumatic fever.
That sounds like something from a Victorian novel. She died of a terrible rheumatic fever.
It's rare now in the developed world because we are so aggressive about treating strep. But in parts of the world where antibiotics aren't available, it's still a major cause of heart disease.
What actually happens?
It's a case of mistaken identity. The strep bacteria has proteins on its surface that look very similar to proteins found in human heart valves, joints, and even brain tissue. So the antibodies your immune system makes to fight the strep can get confused.
And they start attacking your own body.
Exactly. They start attacking the valves of your heart, leading to permanent damage. They attack the joints, causing arthritis. It's a devastating autoimmune response triggered by the infection.
That is terrifying. So the antibiotic isn't just for the infection, it's a firewall to prevent your own immune system from going haywire.
Precisely. And that is why the duration of treatment is absolutely non-negotiable. You mentioned the 10 days. That is crucial. You have to take the penicillin or amoxicillin for the full 10-day course to completely eradicate every last organism from the upper respiratory tract.
So if you stop on day 5 just because you feel better,
you might have killed 99% of the bacteria, but you've left a small reservoir behind. And that reservoir is enough to keep stimulating the immune system and potentially trigger that rheumatic response. Or it could just cause a relapse of the sore throat. So rule number 1 of strep, finish the bottle.
Finish the bottle. Got it. Okay, we've done the ears, we've done the throat. Now let's move up and into the face. The sinuses.
Acute bacterial rhinosinusitis.
The rhino part implies the nose is involved too, right?
Always. You very rarely have infected sinuses without an inflamed nose. It's one continuous carpet of mucous membrane. Think of the sinuses as little side rooms off the main hallway of the nose.
This one, to me, feels like the trickiest of the 3 to diagnose because, frankly, every single head cold I've ever had feels like a sinus infection. You're congested, you have that pressure behind your eyes, your snot turns green. How on earth do you distinguish a regular viral cold from a bacterial sinus infection that actually needs drugs?
You're absolutely right. It is tricky. because the symptoms, what you feel, overlap almost perfectly. The difference isn't in the symptoms themselves, it's in the timeline and the pattern. It's how long and how it happens.
Okay, so it's all about the timing.
It's all about the timing and the pattern of illness. The guidelines give us 3 very specific clinical presentations. If your illness doesn't fit into one of these 3 boxes, you almost certainly have a virus and should not get antibiotics.
All right, let's walk through them. Scenario 1.
We call this one the persistent. This is where you have the typical symptoms: congestion, colored nasal discharge, facial pressure or pain that lasts for 10 days or more without any signs of improvement.
10 days is a long time to feel sick.
It feels like an eternity when you're going through it. But think about a normal cold. Usually by day 5, 6, or 7, you're starting to turn a corner. You might still be sniffing, but you feel better than you did on day 3. With the persistent pattern, you just flatline at miserable for 10 full days or longer. That suggests the virus is gone, but bacteria have set up a more permanent shop.
Okay, that makes sense. What's scenario 2?
Scenario 2 is the severe onset. This is totally different. This isn't a slow burn. This is getting hit by a truck right from the beginning.
Yeah.
We're talking about a high fever that's over 39 degrees Celsius or 102 Fahrenheit, plus purulent, thick discharge or severe facial pain, lasting for at least 3 to 4 consecutive days right at the start of the illness.
So not just, I have a little sniffle, but I am bedridden with a high fever and my face feels like it's going to explode, and it's been like that since day 1.
Correct. That level of intensity right out of the gate is a red flag for a primary bacterial infection, not just a virus.
And scenario 3, this was the one that really hit home for me because I've definitely had this happen. The double sickening.
The double sickening. It's also called worsening course, and it's the classic bait and switch of respiratory infections.
Paint the picture for us. What does that look like?
So you get a typical viral cold. Days 1, 2, 3 are bad sore throat, runny nose, you feel lousy. But then, on day 4 or 5, you start to perk up. The fever breaks, you have a bit more energy. You might even tell your boss, I think I'll be back in the office tomorrow.
You think you're in the clear. You've beaten it.
You think you're on the upswing. And then, around day 6 or 7, bam! Everything comes roaring back, but worse. A new fever appears, or the old one returns. The headache comes back with a vengeance. The nasal discharge, which might have been clearing up, turns thick and green or yellow again.
Ugh, that is the most demoralizing feeling in the world.
It is. But diagnostically, it is gold. That specific pattern, getting better and then suddenly getting worse, is the clearest sign we have. It tells us that the initial virus did its damage, weakened the defenses, and then a secondary bacterial superinfection took over the territory.
So if I experience the double sickening, that's when I should call the doctor.
Yes. Of the 3 patterns, that's the one with the highest predictive value for a bacterial infection that will likely benefit from antibiotics.
Okay, so let's talk treatment. We've fit into one of the 3 boxes. We've got the diagnosis. We have blocked sinuses. The goal, I assume, is just to get all that gunk out.
That's the primary goal. We call it restoring the patency of the ostia.
Which is very fancy medical talk for unclog the drain.
Exactly. The sinuses are just air-filled cavities in your skull with tiny little drain holes, or ostia. When the lining swells, those holes get blocked. Pressure builds up, fluid gets trapped, and infection thrives. We need to open them back up.
Now, I want to highlight a major warning from the source material here. Because again, my gut instinct, and I think almost everyone's instinct, is to reach for the antihistamines. Benadryl, Zyrtec, whatever, dry up.
And I need everyone listening to hear this very clearly. Step away from the antihistamines. They are not your friend during a sinus infection.
Why? It seems so intuitive to dry it up.
It does, but it's based on a misunderstanding of the problem. Think about what antihistamines do. They have what are called anticholinergic effects. They reduce secretions and dry out the moisture in your mucous membranes. But they don't make the mucus itself disappear. They just remove the water content from it.
So you're left with, what, sludge?
Exactly. You turn flowing mucus into thick, sticky cement. And that cement gets stuck in those tiny little drain holes we're desperately trying to open. You are literally making it harder for your body to drain the infection. You're working against the solution.
That is horrifying. I am almost certain I have done that to myself multiple times.
Most people have, because the marketing for cold medicine is very confusing. But for sinusitis, you want the exact opposite. You want to liquefy. You want things to flow.
So what should we be using instead to help with that?
Things that add moisture and thin the mucus. Saline irrigation is number 1, using a neti pot or a saline spray to literally wash out the nasal passages. Steam inhalation, like from a hot shower, is fantastic. And oral mucolytics, like guaifenesin, which is the active ingredient in Mucinex, can help thin the secretions from the inside out.
What about those powerful nasal sprays, the ones that give you instant relief, like Afrin?
Those are topical decongestants, like
Yeah.
oxymetazoline, and they are magic for a few minutes. They work by constricting the blood vessels in the nose, which shrinks the swollen tissue and opens everything up instantly. BUT,
There's always a but.
a huge but. There is a strictly enforced time limit on these. 3 days, maximum.
The 3-day rule, why is that so important?
If you use them for 4, 5, or more days, your nose becomes physically dependent on them. The moment you stop spraying, the blood vessels don't just go back to normal, they swell up twice as big as they were before. It's a phenomenon called rhinitis medicamentosa, or rebound congestion, and it is miserable to break that cycle.
So use the spray for a couple of nights to get some sleep, but that's it.
That's it. Use it strategically, not chronically.
And if we do need antibiotics for the sinuses, what's the go-to?
Here, the first-line choice is usually amoxicillin clavulanate, or Augmentin. We often skip the plain amoxicillin because the bacteria common in sinus infections, especially H. influenza, are more likely to produce that beta-lactamase enzyme we talked about earlier. And for adults, the treatment course is often shorter, around 5 to 7 days.
That's really interesting that we're seeing the same handful of drugs and the same bacteria over and over again.
It makes perfect sense when you think about it, right? We are fighting a war in the same ecosystem, whether it's the middle ear, the pharynx, or the paranasal sinuses, it's all connected territory. And the main invaders are strep pneumo and H flu. It's a turf war in your head.
So let's try to pull all of this together. We have covered a massive amount of biology and clinical guidelines here, but if we zoom out, what is the big picture theme connecting all three of these conditions?
The big picture is about being a detective, not a reflex responder. We are moving away from this old model of, I feel sick, give me a pill, to a new model of, does this specific illness fit the specific pattern of a bacterial infection that will respond to this specific pill?
It really requires a lot more patience from everyone, from patients and from doctors.
It does. It requires trusting your body's powerful immune system for the first few days, and it requires a deep respect for antibiotics, understanding that they are a scalpel, not a multivitamin. They have very specific uses and very significant risks if they're overused.
And I think what we've discussed today really empowers the listener. Instead of just feeling helpless and sick, you're actively monitoring. You're checking for the bulging eardrum. You're looking for the absence of a cough. You're watching the calendar for the 10-day mark or for that dreaded double sickening.
Exactly. You become an active, informed participant in your own healthcare or your child's healthcare. You know what the red flags are.
Before we wrap up, I do want to ask about the future. We talked about how strep pneumo is becoming a tank, more resistant, harder to kill. The source material mentioned rising resistance in H. influenza as well. And at the same time, we talked about how all the guidelines are shifting more and more towards watch and wait and observation. That feels like a paradox. As medicine gets more advanced, are we actually reaching a point where the best advice is often to do less?
It does seem like a paradox, doesn't it?
Yeah.
But I think it's actually a maturation of medicine. For a long time, we had this idea that we could sterilize the body, that we could and should kill every single bug. Now we have a much deeper understanding of the microbiome, of the balance. We realize we live in a complex ecosystem, and often intervening with a blunt instrument like a broad-spectrum antibiotic can cause more chaos by promoting resistance and wiping out good bacteria than just letting the body handle a minor, localized skirmish.
So the future of treating these common ailments is prudent observation.
Prudent observation. It's about supporting the body with the things that actually help. Pain relief, hydration, rest, saline rinses, and only bringing in the heavy artillery, the antibiotics, when the enemy has clearly breached the walls and is setting up a siege.
I like that framing. It's not doing nothing. It's holding the line.
Holding the line. That's a great way to put it.
Well, on that note, I hope everyone listening is holding the line successfully this cold and flu season. Check your symptoms against the 3 signs. Don't use the antihistamines for your sinus infection. And for the love of everything, if you've confirmed strep, finish your 10-day course of antibiotics.
Please, please do. Your heart will thank you.
Thanks for diving deep with us today. Stay healthy out there, everyone.